So we'll start in a couple of minutes, probably 5 minutes. Felipe, are you ready? Your presentation is this?
Yeah, everything's fine. Should I put my web?
Yeah, you can just share your screen and we'll be starting in no time. I'll present you for the rest of the colleagues and then you can start. Hi, Dr. Untracked. How are you?
I'm fine. Good morning, sir. How are you?
Yeah, I'm fine too. I'm covering for Dr. Maya today.
Oh, you are? Very good. Dr. Maya is getting ready to start her residency. So there you go.
Yeah,
but
yeah.
it's only 80 hours a week, not every other night call like in my day. But okay.
Yeah.
Progress.
Yeah, I came to Ryder for 2 weeks, so I'm covering for her.
Oh, you're here at Ryder. You're in Miami.
Yeah.
Oh, cool. Okay.
Yeah, I have a beautiful view here, and it's been very nice.
Yes.
So, Dr. Untracked, could you participate as a panelist today?
Absolutely.
Great, thanks. And Dr. Kasim as well is here. And we have also Dr. Brian. Okay, so we will start in a couple of minutes.
While we're waiting, is Miss Osorio there? Nikuse. I see she's there. I don't know if she's listening.
Yes, I am. Good morning, everyone.
Good morning. Did I pronounce your name correctly?
Yes, yes, Osorio Nekuse, yes.
Yes, okay. So I sent you an email, you and Dr. Martos. Have you seen it?
Yes, Dr. On Track. I saw it this morning. I'm sharing it with my CME office to see how they're going to handle that. And I will go ahead and reply to you.
Okay, very good.
And let you know what's going to be the end result of that.
Yes, okay,
but yes,
very good.
I saw it this morning, yes.
Yes, and I guess, I don't know if Dr. Martos was aware, but apparently it's a very straightforward process, but without the process, then we can no longer use this participation and for satisfying maintenance of certification.
Okay.
So it's a
So they
significant
have
issue.
to be
But anyway,
directly reported to the ACS.
well, no, not the ACS, to the ACCME, which is
Okay,
an
yeah,
accredited.
I'm sorry, yes.
Yes, and then they automatically send it to the American Board of Survey. Apparently, it doesn't cost anything. It's automated, through your computer systems. But anyway, all right, I'll wait to hear back from you.
Yes,
Thank you so
because
much.
I'm sure our Department of Surgery grand rounds, that's
Yes.
probably going to be the same process. They're going to have to do the same thing. Probably.
Yeah, I don't know about anything else. It's only the American Board of Surgery that sent out that announcement that, we have till Friday close of business to upload any outstanding credits. So I uploaded everything I've done so far with the University of Miami and anything else.
Mhm.
So I think probably most CME providers will get to the point where they're automatically going to send their credits directly to ACCME, and then they'll go wherever. So,
Yes. Yes. Yes, Dr. On Track. So I'll go ahead and follow up and I will let you know. Okay.
Thank you. Thank you so much for your help.
No, thank you, sir. Thank you.
Okay, everyone. I think we should start. So it's 12 o'clock here. Let me just prepare everything here. Yeah, so good morning, everyone. Thank you for being here. It's a pleasure to have another international trauma telegram rounds. And today, Dr. Felipe Kfouri is going to present the case. Dr. Felipe is a fellow in trauma and acute care surgery in University of São Paulo. He works with me back in Brazil, and he's a very good fellow. He works a lot, and he's getting a lot of interesting cases for his background. So today he's going to present, and I'll be moderating this session. So I have Dr. Brian, Dr. Kassim, and Dr. Intl here. And we will start the presentation, and as usual, we will stop at certain points to make the discussion more interesting. So Dr. Felipe, feel free to present, and thank you for our presentation.
So good day to you all. I'm really glad to be here. So let's start. We have a 27-year-old male. He was jogging by a shopping mall here in São Paulo, and he was robbed and suffered a gunshot wound to the abdomen. He was rescued by the firefighters corps here, and they just pack the patient and bring to the hospital. So it's just a basic ground ambulance, and the total time of transport was around 30 minutes. His signs on the scene were 90 BPMs, his heart rate. His Glasgow was 14. He was a little bit confused, and his systolic blood pressure was 88. When he arrived at our trauma bay, he had a patent airway. He was a little bit tachypneic, but his O2 sats were 100%, and he had no stigma of chest trauma. He had a 88 by 55 BP and a heart rate of 55. His extremities were cold, and his capillary refill time was around 3 seconds. And his Glasgow Coma score had recovered. He was near 15 Glasgow. And he had an entry wound. I don't know if you can see my mouse here, but in the right abdomen. And we couldn't locate an exit wound on his primary exam. All patients that we admit in our trauma bay here, we do an EFAST examination. This patient was positive in the right upper quadrant and in the pelvic windows, and it was negative on both pulmonary windows. And this his point of care labs. Got a 12 hemoglobin. His pH was around 7.44. His pressure of O2 282. CO2 30, CO3 19, base excess of minus 4.6, and a lactate of 35. Just for reference, our lactate here, our reference value is 5. So he was had a high lactate level. And in the trauma bay, his resuscitation was a liter of crystalloids with ringo lactate, 1 blood pack, tranexamic acid, and it was started IV antibiotics for his penetrating wound on the abdomen. So just to warm up, I would like to know from you, what would you do now? If you do a trauma bay X-ray, a CT scan, or directly to the OR?
Excellent. Thank you very much. So this is a patient with a right upper quadrant gunshot wound with no exit wound, as if I understood correctly at from the presentation. So we'll start by asking Dr. Kassim. Dr. Kassim, what would be your next step, and what about what your considerations about the case? I think you're muted, Dr. Kassim. Yeah.
Good morning. Good morning, everybody.
Morning.
In a trauma case like this, and when a patient is in shock, he's 27 years old, he's compensated well. I think the best thing you can do would be a quick examination, and which should include documentation of peripheral pulses or plus ABI, ankle brachial index. You get a rough idea to see if the lower extremities are perfusing, or if they get traumatized by the bullet by circuitous way. I think if time allows and if you are set up without wasting any time, you should get a KUB of the abdomen plus chest to look at the trajectory of the bullet. And it is just to give you a roadmap in a way you're going to end up later on. Without wasting time, don't send the patient to the CT because he is in shock. He's probably hypovolemic. Not probably, he is hypovolemic. So start your transfusion as quickly as possible. In a case like this, I think I would probably put upper torso in fluid because this patient may have sustained some venous injury to the lower torso, and so it'll be a good idea for you to put either jugular, subclavian, or upper extremity IV fluid and get blood transfusion going. And as quickly as possible, take the patient to the operating room for definitive therapy without wasting time. Every minute you spend here is negative for the patient. And the reason for that is a study from Brady, Atlanta. It showed in a patient who is hypovolemic and major injury to the abdomen, any time spent other than getting the patient to the operating room, more than 20 minutes, their mortality increases. That's the reason why I recommend that you take that patient up to the operating room as soon as possible. CT scan is not advised in a patient like this because he will arrest in the CT scanner, or is the right place for him, and that's what I will do. Thank you.
Excellent, thank you. Dr. Untracht, so we're seeing a patient with a gunshot wound, and he's hypotensive with a systolic of 88 with a right upper quadrant gunshot wound and a positive FAST. Would you add anything from what Dr. Kasim told us?
Well, I agree with everything Dr. Kasim said. I also agree with the resuscitation. That was, I think, well done. I'd be curious, what were the results of the resuscitation? His blood pressure, did his extremities warm up? And so I'd be interested in that data. But I also think an X-ray or two in the certainly of the KUB is a good idea because you don't know where the bullet. There was no exit wound. The bullet could be anywhere, including a as an embolus. So I think that's certainly reasonable. But you know, I wouldn't even if he's a responder to your resuscitation, I would still get him straight to the OR as quickly as possible. I wouldn't go to CAT scan here.
Perfect. Dr. Brian, would you agree with that with the statements from the colleagues that came before you, and would you add anything about maybe anything about the resuscitation or vascular access?
No, I agree 100%. If there's time and it's, or I should say it's not going to delay the case, I would get a chest X-ray and a KUB. Occasionally you can be fooled. There might be a thoracoabdominal injury. There might be an injury low in the pelvis that would make you think of maybe doing like a rigid SIG or something like that. So getting the trajectory, I agree with 100%. But I would take this patient very quickly to the OR without delay. For the resuscitation, I agree with everything. In the military these days, we give the calcium at the same time as the first pack of red cells so that you don't have hypocalcemia. That's all I have to add.
Thanks, great. And I also see Dr. Pust. Hi, Dr. Pust, good morning.
Hey, how are you?
How are you? I didn't get the chance to meet you in Miami yet, but I'll sure look for you here. So, Dr. Pust, would you have any tips for how would you obtain the best vascular access in such cases? Would you do just like Dr. Kasim said, an upper vascular access? Would you use a central line? Would you dissect a vein? What would you do?
Yeah, great to see everybody. Hello. Well, peripheral IVs, a large bore, ideally, 16 gauge. Two of them would be sufficient. If you are unable to get a large bore peripheral IV access, then obviously central access with what we tend to use introducer lines where we can transfuse a large volume up to 500 milliliters per minute. And you have to stay away from the level of injury, right? So you have to think about, so let's say you have a gunshot wound to the abdomen, you're always concerned that you might have, for instance, a vena cava injury or an iliac vessel injury. So it's advisable to stay away from the femoral vessels and rather do a subclavian or IJ access. If you have a gunshot wound to the upper chest in the area of the subclavian vein, obviously you want to stay away from there and go to the other side. So to make sure that the volume or your resuscitation volume, the blood you're transfusing, is actually returning to the heart and not out of the injury into the cavity. And what was mentioned before, obviously, it's important to go to the OR here as fast as possible, as the other speakers already mentioned. It's always in debate here in our institution, should you get X-rays or not, right? We always say, oh, let's do a quick X-ray. The quick X-ray is relative. What's a quick X-ray, right? 1 minute, 2 minutes, 3 minutes, right? If you have a major vascular injury and you're bleeding 2 minutes, it's 2 minutes you don't want to waste. You want to spend this 2 minutes on getting immediate surgical control. As Brian mentioned, sometimes, you want to know, that the bullet traveled to the chest, is it across more than just one cavity or not? So that's why I personally like to get an X-ray and see it. On the flip side, right, if you go to the abdomen, already you're going to do a laparotomy, you can look quickly and see if there's any evidence of diaphragmatic injury or where the trajectory of the bullet is. But sometimes it helps to have an X-ray, but really only if it doesn't delay your transfer to the operating room. So in this specific case, I would not even do X-rays. I would just take the patient straight to the OR.
Excellent. Thank you very much. So, Dr. Felipe, I think you can continue.
So just answering the questions were made, he had two large bore IVs in his upper extremities, and it was considered a partial response to the therapy. He remained normal cardiac and remained with a middle blood pressure of around 70. We have a characteristic here in our service. Sorry, our CT scan is right in front of our trauma bay, so we tend to transport these patients to the CT scan. So I'm sorry to disappoint you guys, but we actually made a CT scan on this patient. Let me show what we found. He has this dense fluid in the abdomen, a moderate hemoperitoneum. And here we can see the bullet right in the right flank and the fracture in the sacrum in the bullet path. This is the arterial phase. In the portal phase, we could see that there is a large retroperitoneal hematoma compressed in the IVC. And the IVC is already compressed in another points, maybe reflecting the hypovolemic state of this patient. And we got this blush contrast stabilization in the mesentery. And in a late phase, I think it was only 5 minutes, we can see that there is some irregularities in the iliac vein with some outpouchings and maybe some contrast stabilization here in the middle of this hematoma. And you can see that the ureter, the right ureter, seems to be away from the lesion. So just to sum up, moderate hemoperitoneum, retroperitoneum hematoma, the collapsed IVC. We got this probable lesion on the right iliac vein with this ill-defined walls and a late phase blush, this mesenteric late phase blush, and this sacral fracture in the bullet path. So this patient was taken straight to the OR. It was done a exploratory laparotomy. He had a zone 3 retroperitoneal hematoma. And it was opted to do direct exploration of the iliac vein. So it was then a medial rotation of the right colon for the exploration of the common iliac vein. And there was a lesion on the anterior face of this vein. And the patient was deemed on this point, both physiologically and anatomically unsuited for a formal repair of the vein. So it was done just a ligation of the vein. I will show some pictures after. And there is also this mesenteric lesion about 130 centimeters away from the right angle, with 4 enteric lesions close to this lesion. It resulted in a 50 centimeters resection. And it was opted to do a temporary closure of the abdomen with a Barker pack. So you can see here, we have the right iliac artery in the vessel loop, the left iliac vein in the tip of the forceps, and on the tip of the forceps now, we've got the proximal stump of the ligation of the common iliac vein, right common iliac vein. And on the tip of the right angle, we got the distal stump of the same ligation. A little bit more pictures showing from different angles. And this is the total enteric resection that was performed, around 50 to 60 centimeters. And the total resuscitation during the case, the cell saver was used. A liter of blood was recovered and retransfused into the patient. And alongside with that, it was administered 4 blood packs, 4 plasma packs, and 1 apheresis with 2 grams of fibrinogen and 2 liters of crystalloids. And this is his response to the resuscitation. Notice that he started with a transitory tachycardia, sorry, on the beginning, the circles here, but then he responded better to the resuscitation, and he remained a bit hypotensive, even with the use of vasopressors. And the total operation time was around 1 hour and 40 minutes. And this is his microcirculatory response. Notice that during the intra-op, he became a little bit acidotic, but in the post-op, he recovered a little bit. The lactate only cleared after the surgery, and the basic says as follows. So anyone would like to comment until that point?
Okay, thanks. So I'm going to do a round here again, and let's start with Dr. Brian. Dr. Brian, would you do anything different? I mean, you already agreed with the other panelists about not doing the CT scan and going straight to the OR, but once you are in the OR, would you do anything different? Would you consider a different approach than that was presented?
No, I think it's appropriate if you can't repair the vessel to ligate it. I don't have a huge experience with these types of injuries. You can see one in 2020 in Syria. They can take a long time to repair, especially if it's a gunshot wound. It's like an unclean, fragmented area of tissue to repair. And sometimes when you repair it, it becomes so narrow and it probably will thrombose anyway. So I wouldn't feel bad about ligating an iliac vein. Some people would do prophylactic fasciotomies if you ligated. I don't know if that's known 100%, but some people would think about that, or at least monitor the patient's compartments afterwards. But I think that's fine. The only things that I would maybe say, or maybe some learning points, are whenever you have a venous injury, inspect the artery, because they're often an arterial injury. in combination with the vein, and make sure you get good proximal and distal control. That's all I have.
Great, thank you. Dr. Pust,
I agree with Dr. O'Connor. I think you should ligate those vein injuries with impunity. I mean, there's really no issue to ligate a common iliac vein or external iliac vein. Specifically for gunshot wounds, usually the damage is so significant that it's not a simple repair, and that what happens, as Brian mentioned already, most of the time you're going to end up with a narrowed vessel, and then you're going to form a thrombus, and then if you didn't ligate and did a repair, now you're at risk to developing a DVT PE, right? And then the patient could theoretically die from your PE. So it's really not an issue to ligate that vein. Same with a distal vena cava. You can always ligate vena cava also. It's not a problem. So you shouldn't waste time on trying to repair this and have more blood loss than needed. Regarding the concern of compartment syndrome and fasciotomies, typically, if you didn't have a prolonged ischemic phase, if you have an arterial injury, you're fine usually. If you had a combined arterial injury and you had a significant time for reperfusion and you ligate the vein, now you have to be much more concerned for developing a compartment syndrome, and you may consider to do empiric fasciotomies, depending on how long the ischemia time was. Typically, if you just have to ligate the vein, leg elevation and stocking or compression bandages are sufficient to avoid major swelling. The other thing is, I just want to go back to the issue with the CT scan. It's interesting, right? You could. The question is, what does the CT scan change in your management, right? Does it change your operative approach? It really didn't in this case. What you did see on the CT scan is that your iliac artery was intact, so you didn't have to worry anymore about too much intraoperatively, because you already knew the CT scan showed that it was a normal CT angiogram of the iliac artery. But it's really concerning that you have, ongoing bleeding from a major vein while you're in CT scan, right? And you saw that the patient went into more shock during the OR state because you were just behind, right? You had to catch up and you delayed until you controlled your bleeding. And so, there's no fast CT scan, right? Even if the physical location of the CT scanner is right opposite the trauma bay, the reality is, you're doing delays as you did there, that alone you wait a few minutes to get your delay phase in the CT scan. So, that CT scan probably took at least 15 to 20 minutes. Maybe you can tell us what the time was from patient arrival to time of incision in the operating room. But it didn't change, the CT scan did not change your management at all, but it delayed control of hemorrhage, right? But I think the decision intraoperatively to ligate the vein was absolutely correct, and to do damage control was absolutely correct decision as well. And I have one more question for the presenter, maybe at the end you can go back, is are there any concerns to using the cell saver in the setting of intestinal injury when you have potential contamination? Maybe you can address that too. Thank you.
thanks, Dr. Pust. Dr. Untracht, could you comment? Could you give us any tips that you would use in a case like this, if you want to address the injury that now is a iliac vein? How would you approach this in a technical aspect?
Yes. So firstly, about the CT, and I agree with everything Dr. Pust said about the CAT scan. And the issue is, if you spent 5 minutes, but 5 minutes maybe, but then looking at the films and interpreting them. So however much time you spent, if that shortened the operation by 30 minutes because you knew exactly what was wrong and you can go there, then you could perhaps justify it, especially given your infrastructure where the CAT scan basically in the trauma bay, and if you can do it quickly and in and out, and the doctors are there with the patient, I think you have to balance all those factors. And assuming you get a good outcome, if you got a bad outcome, then someone would say, okay, you spent too much time and the patient went into shock and it became irreversible. About the approach you took, I think that's fine. You did a visceral rotation, did the ligation, and that's fine. The only other consideration, depending on how much flow is in the was in that vein, you could consider possibly putting a venous shunt, but then again, that might just thrombose anyway, or worse, you can, as Dr. Poos said, you might get an embolism through the shunt. That's the only other consideration. But I think your approach was fine. It looks like based on the CAT scan, you're able to very quickly get to the problem without spending a lot of time exploring. So the only question I have is, I assume you didn't do an anastomosis, you just stapled across the two ends of the bowel and left them stapled, right? Yeah.
Yeah, we buried the step. So I'm sorry, forgot to talk about that.
Excellent. Dr. Kassim, would you like to make additional comments about the case, about the approach, and also if you please could comment on the prophylactic fasciotomy, as well as Dr. Brian raised the discussion, and also about using cell savers in such situations, just as Dr. Poos raised this discussion.
There is a very famous saying, it is better to be lucky than good. Okay, so let's start with that. So in my opinion, a CT scan is not going to really contribute to the management of this case, because you know from your own intelligence what you're looking at in a patient like this. He's got a gunshot wound, he's in shock, and he's bleeding. So what is the dictum in surgery? Stop the bleed, because that's where the patient is going to die from, hemorrhage. So in my opinion, a CT scan is going to be superfluous in a case like this. Yes, I can see your CT scan is right across from the trauma bay. It is very tempting to get the patient to the CT scan because that's what your superior will say on Monday morning round. But don't get tempted into this. You know, do the right thing. Right thing is the patient belongs to the OR. You are very, very lucky you got away with this particular case, but this may not be the case the next time. You know, you may get burnt. So very nice. You took the patient to the operating room. So what is the thing that I like about what you did? You immediately did the right Catal maneuver, which is right medial rotation, and you identified exactly where the patient was bleeding from. And I assume that you probably use the sponge stick technique, two sponge stick technique, one above, one below to stop the bleed. And then you pondered for a minute, shall I put a shunt in here or shall I go ahead and ligate it? And the easiest thing to do would be to ligate it, and which you did. I admire that, because again, I'm still thinking, stop the bleed. You know, if the patient is bleeding, you stop it. If you ligate it, it'll stop it, no question. If you are going to shunt this area, you're going to be wasting time, and it is not really going to contribute to the well-being of the patient because he is bleeding. Next, you finish doing that, you stop the bleed, and then you look around and you find several holes in the bowel, and you prudently went ahead and resected it and stapled it. Now, why you did that? Because the patient is hypotensive, and you have been taught by your superior, don't do an anastomosis when the patient is hypotensive, because the propensity for leak is very high. And you went and stapled it and got rid of all the injured viscous and got the patient stabilized at least. And now, regarding cell saver in a situation like this, I would be very leery to use cell saver when there's a contamination going on in the peritoneal cavity. But I can understand that you wanted to save the blood, and you're not putting any foreign material in the abdomen, such as grafts, Gore-Tex graft or anything like that. And you said, okay, I'm going to use a cell saver to minimize exogenous blood transfusion. And I think it is acceptable, but in my hand, I try not to do that because I would be afraid of ongoing sepsis later on. And so whatever you did here in this particular case, the only thing that I would be critical of would be the CT scan. But again, don't knock it when you're winning. My teacher told me, when you're sitting on a winning horse, don't get off it. And you're doing great. And I like everything that you have done. Thank you.
Thanks a lot, Dr. Kassim.
Oh, regarding fasciotomy.
Oh, yeah.
Again, Dr. Poos is quite correct. Fasciotomy is indicated when there is combined arterial and venous injury together. In this particular case, fasciotomy will be, again, superfluous. Thank you.
Great, thank you. Dr. Felipe, you can continue.
Responding to Dr. Kassim and Dr. Pust about the cell saver. As there wasn't any gross contamination of the abdomen, we did a recent review of the literature, and we found that even when there is enteric lesion, if there is no gross contamination, the risk of post-op sepsis is quite low. So we tend to use cell saver in this case if there's no gross contamination and everything is controlled. And about the time that the CT scan may be added to the case, it was around, I guess, 20 minutes that the CT scan added to this case. So this is I'm sorry. This is post-op evolution. He was discharged from the room with vasopressors with noradrenaline at 0.1 microgram per kilogram per minute. He was extubated right in the post-operative, immediate post-operative period. In his first day of hospitalization, we could wean out the vasopressor to half the dose. And on the second day, we weaned a little bit more to 0.04 micrograms per kilogram per minute. And then he went back to the OR for the revision of the peritoneostomy. It was lateral to lateral enteroenteral anastomosis was performed. The abdomen was closed. And here, when we have a peritoneostomy, we also tend to put a preoponeurotic mesh on these patients, kind of off-label, I guess. And we put an abdominal drain and a subcutaneous drain to watch the mesh. His further evolution in his fourth hospitalization day, it was introduced low-weight heparin, and he was discharged from the ICU. And on his 7th hospitalization day, he was discharged from the hospital with factor 10 inhibitors, rivaroxaban. On his outpatient follow-up, he's around 1 month of follow-up as an outpatient, still using rivaroxaban and elastic socks. He has minimal edema in the right limb, and he's walking normally by now. So, you want to comment?
Yeah. So let's start now with Dr. Untracht. So, Dr. Untracht, do you want to comment these suggestions from Dr. Felipe? You're muted, Dr. Untracht. Yeah, that's all right.
All right, so I guess that's reasonable. I haven't reviewed the literature recently, but I think you ligate the if you ligated the common iliac vein, minimal edema, and he's on anticoagulation, you're doing well. So I would be prone to continue it for what, 3 to 6 months, I suppose. Although I would do some research on that. Extubation before the planned reoperation. You know, if the patient was awake and he really wanted the tube out, he was pulling at it, I think that's reasonable, you know. Either way, it's okay. And you know, the pre-aponeurotic mesh, you mean as an onlay graft? Is that what you did? As an onlay graft?
Yeah.
Yes. And so you couldn't bring together there's a midline incision, I assume. The fascia was okay. You couldn't just do a primary closure.
No, we could perform a primary closure. It was done like a hernia surgery. The fascia was okay. It was primarily approximated, and it was done only. Just
Dr.
like to
is a prophylactic mesh reinforcement.
Yeah, it's a not an absorbable mesh. It's Prolene mesh.
Yes. Sorry, Prolene mesh.
Prolene mesh. You know that if that works for you, if you do it routinely, that's fine. I don't know that I would have done that in this case, but that's just been my experience not to apply it primarily. The plastic surgeons talk about, you know, the component separation. You know, you can if there's too much tension on the closure, you can free up, make relaxing incisions to free up the fascia and do a closure under no tension, and that seems to work well also. But you know, different ways to do things, and if that's your approach all the time and this works for you, then you know I can't argue with it.
Awesome, thank you, Dr. Kasim. Would you do any additional comments? And also, I noticed that the patient had his prophylactic heparin on postoperative day 4. Would you do anything different from this kind of approach?
Yes, I think I would have started it a little bit earlier, perhaps on the second day, but I think it is esoteric whether you do it on the second day or fourth day. But the patient does require some type of anticoagulation therapy because literature shows these cases, they do have a propensity for developing thromboembolic problems postoperatively after you've ligated a reasonably large vein, such as the iliac vein. And how long do you carry this on? Some people say for 3 months, other people say for 6 months. And I think you can take an average between 3 and 6, and somewhere in the middle you can stop it. I think the patient has done very well because young Philip has done a fabulous job, and I think he got the patient out of the hospital on the 7th day, which is remarkable in a big gunshot wound like this. And all in all, the patient got very good treatment and a very good outcome at the end. I wouldn't change anything what Philip did. I think everything that he has done is very, very acceptable in my hands and in my view. Thank you.
Thanks a lot. Dr. Pust, would you like to comment anything on that regard? And also, what about the experience from Ryder in terms of extubating the patients between the planned reoperations? Do you do that, or do you keep the patients intubated?
Yeah, thank you. Yeah, first of all, I agree with Dr. Kasim. This is a great save. You got the patient home in 7 days from a major vascular injury. It's good. Those young patients have great physiologic reserve, and he recovered very well. And so it's a fantastic save. Remember, the mortality on iliac vessel injuries is very high, especially if it's combined iliac artery and vein is easily up to 50%. So it's a great save. In terms of the mesh, personally, I don't think there's any data supporting it as far as I know. You know, if you have a healthy patient and you're able to reapproximate the fascia on closure, there's no need to do any additional mesh placement. I don't think it will lower your risk of hernia formation postoperatively, especially not an onlay mesh. The other concern is, what about mesh infection, right? So you did had some contamination with intestinal injury, not colon. Certainly wouldn't put a mesh in if you had a colonic injury, but you still had small bowel injuries and contamination, and you had an open abdomen, which you take back 24 hours later and stuff. So there's also some skin flora exposure there. So I don't think putting a permanent mesh in is the way we would hand it here in Miami. But that's why I love this conference, because different places do different things, and some people are successful with it. But maybe you have data on that supporting it, but that's would not be our standard of care. Let me put it this way: if we cannot get the fascia together on closure on the first post-op day, we put something what we call the ROA, the right open abdomen retention system. So some sort of retention sutures in the fascia to try to keep traction in the fascia. And then we are very judicious with our fluid management in the ICU, doing diuresis, considering mannitol, hypertonic saline, and so on, to get the bowel edema down. And really your goal is to close the abdomen, within the first 7 days. Every day you have an open abdomen, your risk goes up of fistula formation and so on, right? So you're trying to get the abdomen closed. Some patients, you will not be able to close it because it's just major injury and massive inflammatory response and the swelling doesn't go down. You may not be able to close it. Then we at times put in absorbable mesh to cover the bowel, and then may just close the skin only if we couldn't get the fascia closed or if we had loss of domain. But we really trying to avoid loss of domain. But I would be very concerned to put in permanent meshes in those kind of patient populations. I think it's rather acceptable that the patient will develop an incisional hernia, or leave him with an incisional hernia and come back a year later and then do an elective interhernial repair, and you place your permanent mesh at that time. It's probably the way to go. Regarding the anticoagulation, that's a very interesting topic, right? So you ligate the vein. So obviously you're going to have thrombosis distal to the ligation. And then the question is, is the clot going to propagate more distally, causing major leg edema and need for anticoagulation? And I think nobody really knows, how long should you anticoagulate those patients, or if they need anticoagulation at all. All the patients who have long bone fractures, we discharge on anticoagulation home, because, we've seen that there's significant risk to develop DVT after hospital discharge. This specific patient, I don't know. You shouldn't get a PE afterwards, right? Because you ligate the vein. So I'm not sure if he needs full anticoagulation for several months. I probably would only anticoagulate him if he develops significant leg edema and you do an ultrasound and you see that you have DVT now extending down the femoral vein and popliteal vein. Then for sure I would do full anticoagulation for 3 months at least. But if that's not the case, if he has good outflow through collaterals and he doesn't form distal DVTs, he probably doesn't need it when prolonged after hospital discharge. But I don't think there's any specific data telling us, if you ligate the iliac vein, you need X amount of months of anticoagulation. But I would be much more concerned if I did a repair. So if you did a repair of the vein that's somewhat narrowed, those patients I would anticoagulate and send them home on anticoagulation. And that's it. Again, congratulations for a great safe and great management.
Thank you, Dr. Post. Thanks a lot. Dr. Brian, would you agree? Would you do any additional comments?
I think all the important points were hit. I agree with my other colleagues. I don't think anybody knows for this patient or even other patients whether full anticoagulation is indicated. You're going to maybe decrease the risk of a PE, but you may increase the risk of some other complications. So it's impossible probably to know exactly where the risk and the benefit lay. I think everybody sounds like they would be fine with like a prophylactic dose. I think that's always a great idea. As for the mesh, I've not heard of anybody routinely putting in mesh. I don't know what the concern was. If the patient went to the operating room like the next day, there really should be no loss of domain, and it should not be difficult to get the abdomen closed. This guy sounds like he's young and relatively healthy, so he would not be at very high risk of any complications. And if you were worried about, the only thing that puts him at risk or like a wound dehiscence or something like that, which is contamination of the abdomen, is the same thing, which would be a contraindication to be putting mesh in the first place. So I agree it was a great save, but if this guy came back with a mesh infection and then he required another surgery, I think that would be like stealing, defeat from the jaws of victory. So I disagree with that part. I would say if you really felt like you wanted to put a mesh, then maybe a biological mesh would be more acceptable to most people because of the decreased incidence of a mesh infection. That's all I have.
Okay, that's great. Dr. Felipe, do you have any more comments on the case?
I have a very brief review.
Yeah.
It's like 3 minutes, I guess. So just about the anatomy of the case, this is actually a cadaveric dissection we did after the case to explain it a little bit better. But I won't be further on the anatomy. I don't plan to teach you iliac anatomy, but just remember that there are variable branching patterns in the iliac system, and they can difficult the treatment during acute bleeding. But there is also rich anastomotic and collateral paths that allow ligations in certain points of the iliac system, mainly in the common iliac system, because there are distal collateral paths. I could find just this big series from this century. I guess this is the biggest one I find. It with 148 patients. 94% of the patients with iliac lesions were from penetrating injuries, and 91% was from gunshot wound injuries. And the survival rate on this series from a sensor was around 51%. So it's a very severe lesion. And there is this huge review with the National Trauma Data Bank. It's a coding study. It's a retrospective study. There's a lot of things that we should take with a pinch of salt, but we can see that these injuries are very rare. They account for approximately 1% of the lesions when we got a gunshot wound, and in trauma, abdominal trauma at all, it's 0.2% of the lesions. And about the complications that these lesions present, as it was Dr. Pust that told us about the risk of PE. The risk of PE in the repair group was bigger. It was around 3 times bigger, but notice that they couldn't reach a statistical power to prove that, but there's an important numerical difference here. And about the fasciotomy rate, it was bigger in the ligation group, but again, no statistical power. And amputation, it was sort of similar. But what's most important maybe in this article, it's about the mortality, 30-day mortality. You can notice that the ligation group has more than double the mortality of the repair group, but maybe that's just a selection bias. Maybe the ligation group, they were just more severe patients that couldn't be repaired, and that's why they died more. They did a logistic analysis of these patients, but I don't deem it to be enough to exclude all the factors of severity of these patients. So I guess it's iliac vascular trauma. It's a rare entity. With this data, we should favor a repair when it's technically feasible, but ligation is okay with a high mortality rate on both groups. I'd just like to thank my mentors, and especially Dr. Carlos that invited me today here. Thank you.
Okay, thank you, Dr. Felipe. Thank you very much for presenting the case. Does anyone have any additional comments to make? Dr. Untrak, Dr. Pust, Dr. Kasim, or Dr. Brian? Any additional comments? Okay.
I think there is very great presentation. Thank you so much. As you pointed out, Felipe, I think it's very important that you mentioned that it's highly likely a selection bias. If you look at the mortality ligation versus repair, Typically, right, when the patient is in extremis, you rather quicker going on and do a ligation. And if it's a smaller injury with less blood loss and the patient is stable, then you may attempt a repair. I've seen a couple of cases where we lost a patient, trying to repair the KFOR when we should have ligated during fellowship, and I learned from it. And I realized afterwards, with the ligation, and many of those patients who have a major gunshot-wound injury to the vein is most of the time the way to go, especially if the patient is in shock. So you mentioned right. So don't confuse the data and think like, oh, the mortality for ligation is higher because we ligate, right? The mortality is higher because the patient are more extremist and the blood loss is higher. So I just want to stress the importance that there's no problem to ligate iliac veins, vena cava, especially below the renal veins, and save the patient in there rather than ligating. And again, the other thing is when we do a repair, right? I'm sure there's much more cases of clinically indifferent PEs, meaning like there's probably more PEs, we just don't know about it, right? Because it may not be symptomatic. And I guess if it's not symptomatic, it doesn't matter in the end. But it's probably higher than we think, the rate of PEs when you have a narrowed vein repair. That's all. Thank you so much. Great presentation.
Thanks, Dr. Pust. Did anyone wanted to make another comment? I don't know if Dr. Kasim or Dr. Brian, they started.
I was going to tell you that there are two factors that helps in reducing mortality on patients like this. First, I like the scoop and run in a case like this, where the paramedic do not waste time to get the patient to the appropriate medical center for definitive treatment. And sometimes, extrication, messing around in the scene, they spend a lot of time, and it's a waste of time, in my opinion. I think I like the way in this particular case, the paramedic or the ambulance people got the patient to Felipe and his cohorts in a timely manner, within 30 minutes. And the second thing is, I think you should, as surgeons, especially young surgeons who are on call in the middle of the night when the superiors are fast asleep, you must have a protocol in your mind. How are you going to manage this? And it should be sequential, This is what exactly I'm going to do when I encounter a case like this. Like the Colonel Brian, he said that he hasn't seen too many cases like this. He saw one in Syria. And these cases are not frequently seen by young surgeons. And the case that Felipe presented today should be something to think about and have a protocol available in your mind or in the OR, that when we encounter something like this is exactly how we can manage it, plus or minus fasciotomy, plus or minus putting an abdominal graft in closing the wound. And those are all, not going to contribute to the patient's longevity, but you must have a protocol in your mind. And this is a good case to learn from that. Thank you.
Okay, thanks a lot, Dr. Brian. Do you want to make any final comments? I don't know if Dr. Brian is still here. He told me that he would have to leave a little bit earlier. Okay, so that's it. Thank you very much for everyone being here. And I thank you again, Dr. Felipe, for presenting the case. Thanks, Dr. Untracht and Dr. Kasim, Dr. Pust, for the very interesting comments. We always learned a lot. I always learned a lot in this presentation. That's why I love so much these meetings. So thank you very much, and I'll see you again on the next week. Bye-bye.
Bye-bye. Good to see you, Carlos.
Yeah, I'll find you in Rider.
Just a reminder that the CME code is in the chat, everyone. CME
Oh yeah,
is in the chat.
Yeah. I'm sorry, Kevin. Yeah,
Carlos, are you going to Fortaleza to PTS meeting?
Yeah, I'll be there at Florianopolis.
Yeah, Florianopolis. I'm sorry. Yeah. See you there. Looking forward.
Yeah, sure.
Okay, take care. Bye-bye.
You too. Bye-bye.